Okay. So again, good morning, Section B. This morning, I'll be talking about the coverings of the biggest cavity in the body, which is your abdominal cavity. Okay. So anatomically, you have a lot of solid organs and hollow organs situated inside the abdominal cavity. And the only protection of the abdominal cavity would be your abdominal wall and its components. So, aside from that, we will also be discussing uh, an area which is closely associated with the abdominal wall. Uh, Closely associated in such a way that structures from the abdominal wall as it goes down, going to the pelvic region and into the perineal area, would form part of the structures and even the enclosures of the inguinal canal. So, for us surgeons and anatomists, the picture that you see on the right side is what we call the anterior abdominal wall. Well, of course, the abdominal wall would be continuous, right? And it goes at the back. So that you also have a posterior abdominal wall. No? But uh, that lecture will be given later. No? So we will be concentrating our discussion for this morning in the anterior abdominal wall. You see lines here on the right side, right? Imaginary lines. So these imaginary lines are the lines that we make use of whenever we start dissecting our cadavers, or even when we make use of these lines for our incisions that we make, in surgical procedures. Now, as I've said, the most important function of the abdominal wall is to protect the organs inside the abdominal cavity. So your hollow organs, when you say hollow, you have a lumen, like your intestines, your stomach, your small intestinal segments, your large intestine. These are hollow organs or hollow viscous. And your solid organs. No? Solid organs, you have your liver, your pancreas, your spleen. Okay? So any organs that are found in the abdominal cavity, in general, we call the viscera. So viscera. Aside from that, your abdominal wall will also help in the process of respiration. Okay? Now, you all know that from the previous lecture, the diaphragm is the major muscle of respiration, right? So that the muscles in the abdominal wall will help process of respiration. And how will it do that? So by the contraction of your abdominal wall muscles, this will squeeze the abdominal cavity, thereby increasing your intra-abdominal pressure. So that the increase in the intra-abdominal pressure can either push the diaphragm up or down. So that's why your abdominal wall muscles are accessory respiratory muscles. Okay? Lastly, this will also help in the elimination of waste products. Pretty much the same mechanism as how it helps in your respiration. By altering the pressure, the intra-abdominal pressure, this is able to push solid waste out of the body via the anal opening, or squeeze in also urine from the urinary bladder. Okay? So the main uh, factor here would be the change in the intra-abdominal pressure. Now, ever wonder why, if you are experiencing coughing, no? Repetitive coughing, especially if it becomes more frequent and uncontrollable, to a point that every time you cough, you would experience urine coming out, no? So of the bladder, no? So that's the mechanism by which this affects elimination of your solid waste products, or even your urine in the body. Okay, now here's another illustration showing you the extent of your anterior abdominal wall. Now, we can make use of two sets of structures for us to delineate the boundaries of the anterior abdominal wall. One, we can make use of your bony landmarks, so your bones, no? Okay. And number two, your soft tissue markings. Okay. So two things that we can make use of in delineating the boundary of the anterior abdominal wall, and likewise help us in localizing structures within the anterior abdominal wall. Insofar as the bony structures are concerned, note that on the right side again, you have the boundaries of your anterior abdominal wall, and it starts off superiorly with your xiphoid process. So the xiphoid process is the highest boundary of your anterior abdominal wall. And as you go down the subcostal region or your costal margins, this will also form part of the boundary of your anterior abdominal wall. When you go back, so posterior, so again, this is in reference to the anatomical position, okay? So we are talking of anterior structures, all the structures that we see here in the abdominal wall. But the limit or the boundary at the back or posterior would be your vertebral column. Okay? Now, as you go down, more inferior, the inferior boundaries would be that of your iliac crest, your inguinal ligament, which is obliquely oriented, and your pubic bone. So in its entirety, this is the coverage of your anterior abdominal wall. Again, showing you this illustration. So superior boundary, your costal margins, your xiphoid process here. As you go down, so this extends to a more lateral orientation on the side. Okay? And then you have your iliac crest here, your inguinal ligament here, and your pubic bone. So next set of structures that we can make use of are your soft tissue markings or your soft tissue structures. Okay, so very prominent would be the vertical muscle that you see in front of the abdomen. And this vertical muscle that you see, your rectus abdominis muscle, which is a paired structure that you see, is divided by a horizontal line that crosses your rectus abdominis muscle. This is what you call your tendinous insertions or tendinous intersection. Normally, you have three of these lines, three horizontal lines. that starts off in the subcostal region at the level of the umbilicus, and the last one would be midline or midway between the umbilicus and the pelvis. So this tendinous intersection is responsible for forming your so-called six-pack. Okay? So if you look at the body of a well-toned individual, so you see the outline of the rectus abdominis muscles, and this is divided into compartments. So this is responsible for that, your tendinous intersection. Now at the midline is a free area. So a free area which is made up of the extensions of the fascia of your rectus abdominis muscle. This is also a vertical line that you see at the middle. Okay, and this is what you call your linea alba. Your linea alba. Okay. Now, as you go more lateral here, you would note again another vertical line, which would be the meeting point of your rectus abdominis muscle and the aponeurosis of your lateral abdominal wall muscles. Your lateral abdominal muscles are made up of three muscles: your external oblique, your internal oblique, and your transversus abdominis muscle. Now, the orientation of these muscles is that as they go more medial, the fibers of the muscles becomes more scarce, and then it is replaced by your aponeurosis. So these are fascial extensions of your muscle so that you won't see your fibers crossing the midline. And this aponeurosis, the meeting point of the aponeurosis of these three lateral abdominal wall muscles and that of your rectus abdominis, form your linea semilunaris. Your linea semilunaris here. Okay? So this would be the meeting point of the border of your latissimus dorsi and your aponeurosis of the lateral abdominal wall muscles. Okay, now your rectus abdominis muscle is a continuation of a structure in the thoracic region. If you would remember, I mentioned this in my lecture in the thorax. Okay, so uh, what structure is this? Okay, if you can recall, your rectus abdominis is an extension of what structure in the thorax? Anyone? It's actually there in the picture. No? The answer is there. Do you remember? Or you forgot it now? Because that's part of the midterms. It's an extension of your transversus thoracis muscle. So you see here, okay? Diba? So this is your transversus thoracis here, okay? As it goes beyond the subcostal, so this now becomes your rectus abdominis muscle. Okay? So this is an extension of that. Now another anterior muscle is that of your pyramidalis muscle. This is a very, very small muscle here. Okay? Pyramidalis muscle at the end of your rectus abdominis muscle. Now, there are individuals who don't have your pyramidalis muscle. That's okay. So that's a normal variant. So it's not abnormal to see an individual without a pyramidalis muscle. Okay. Oh, by the way, no, I before I leave this, no, there's another line midway between the umbilicus and the pelvis here. We call it the arcuate line. And the arcuate line is important because at this point, um the the coverings, no, of your rectus abdominis muscle, your rectus sheath, uh, changes, no? Changes in such a way that before the arcuate line, you have anterior and posterior rectus sheath covering. No? But here, as you go down, only the anterior portion would be covered by your sheath. And as you go down here also, at the level of the umbilicus, the subcutaneous layer also changes. And we will be going to that in a while. Okay. Now, the skin covering in the skin covering the anterior abdominal wall is unique. Unique in such a way that this is very elastic, and this accommodates the change in the abdominal wall. Now, I am particularly talking about during the time of pregnancy, wherein the abdomen becomes bigger because of the developing baby inside the uterus, right? So the skin becomes stretched. And this is part of the accommodation of the covering of the skin in the abdominal wall. Now, also, like any part of the body being covered by the skin, you have natural lines that are seen in the skin, which we call your Langerhans lines or your lines of Langerhans. These are normal creases in the skin wherein we follow and we make use of putting our incisions whenever we do operations. So why is this important? If you follow your incisions, if you follow your incision through the lines of Langerhans, then healing will be faster and the appearance will be much, much more pleasing. Okay? And you will have less scarring in the area. Okay. So these are your Langer lines. So they are equally distributed in the entire body. And in the anterior abdominal wall, you see here, uh, initially they traverse the anterior abdominal wall horizontally, but as you go down below the level of the umbilicus, they will have a slightly oblique orientation. But the good thing here is when you do your midline incision, when you do your midline incision, you will not cross your lines of Langerhans. You will not cross your lines of Langerhans because the lines of Langerhans will meet in the midline. Therefore, this will not really affect much your healing and the cosmetic appearance of your incision. Not unlike the other areas of the body. Okay? So, looking at the extent of the anterior abdominal wall, no, and peeking through what's inside the abdominal cavity, this will be the outline, more or less, of the structures that you will be seeing in the abdominal cavity. So it's a mixture of solid organs and hollow organs. You see here the liver, no, your stomach, the spleen here, no, also at the back, no, with the lines that you see here, your pancreas, your ascending colon, the appendix, the transverse colon, your descending colon, rectus sigmoid area, and occupying the middle would be the loops of your small intestinal segments. Um, Very difficult to localize, right? Because you have a lot of structures inside. That's why in the hospital, in the clinics, whenever we see a patient, especially if the patient complains of abdominal pain, we make use of uh, a method so as we'll be able to localize intra-abdominal structures in one area of the abdomen. And how do we do this? Number one, we can make use of the four quadrant method. Four quadrant method. This is made by drawing a vertical line from the xiphoid process all the way down to the pelvis, transecting the umbilical area. And another line, a horizontal line, that will be perpendicular to your vertical line at the point of your umbilicus. So this will divide the abdominal cavity into four equal quadrants. Right upper quadrant, left upper quadrant, right lower, and left lower quadrant. Anyone here operated on acute appendicitis before? Ha? None? Wala pa? Or you know of somebody who was operated for acute appendicitis? So if you're, yes, Dr. Magalo,
Yes.
you were operated already?
Opo.
Okay. No? So during that time, what did they ask you? Or how did they explain to you?
I was still a child back then po. Pero as I remembered, parang pain was surging towards my yung sa area ng umbilical. Parang papunta siya sa gitna do.
Okay. So it started in the periumbilical area and then gradually localized here in the right lower quadrant area.
Opo.
Ganun, na? Okay. So that helps the surgeon localize the area. No? So by making use of the quadrants. And pretty much the same also if you are experiencing pain in your epigastric area in the right upper quadrant area, which is very common. And we associate it with acute cholecystitis, a problem in the gallbladder. Okay? So another way of localizing structures in the abdominal cavity is making use of your regions. No? So these are smaller areas, 9 regions actually, uh, to compartmentalize structures in the abdominal cavity. Now this time, the umbilicus or the umbilical area will have a specific area already, not just a point of transection. So that you will have a right hypochondriac area, your epigastric, your left hypochondriac area, your flanks, right and left flanks, the umbilical region, and the right groin area, your pubic region, and the left groin area. So smaller areas and more specific structures can be placed here. Like if you're having pains in the flank area, the first thing that comes to mind would be your kidneys because your kidneys are in the flank. Okay? In the epigastric region, if you have pain in the epigastric region, the first thing that comes into mind would be your stomach or the pancreas. Okay? So that's how we divide. Either way, whether you use your four quadrant method or your 9 region method, that's okay. No? So it's a matter of preference. And it's according to the cases that you see. So you can make use of both. Okay, if you're using the 9 region pattern, these are the structures that you can localize in the specific region. Okay, so you have a lot, no, and there are times wherein they are overlapping. No, it overlaps from one region to another. So I will not go into each and every one of these structures. You go over it, no, and associate it with the specific area in the abdomen. So this will help you later on when you are already looking at your patients and trying to find out what is a problem of your patient. Okay. Any questions so far or clarification? Questions?
Wala po, Dok.
None. Okay. Okay. So uh, let's talk about the layers of the abdominal wall. Of course, we will be encountering these layers, especially if we are uh, doing operations in the abdominal cavity or dissecting the cadaver in the laboratory. Well, hopefully, during the second sem, we can have our face-to-face already. I understand that we are already granted face-to-face privileges. I just don't know when are we going to start. So, but we will keep you posted, and we can see each other in the laboratory and make use of our cadavers. But anyways, uh, these are the layers of the abdominal wall that you will encounter as you go inside the abdominal cavity. You have the skin, of course, the most superficial covering, your superficial fascia, your muscles, your extraperitoneal fascia, and your parietal peritoneum. So you will be going through each and every layer as you go inside the abdominal cavity. Now, the only thing that will change is where exactly will you be putting your incision. Okay? Where exactly where you're going to put your incision. Because if you put your incision in the midline, then definitely you will not encounter your lateral wall muscles. Because as I've said, no, as it goes along the midline, what you will see will be your aponeurosis, the aponeurosis of the muscles. So that will be different. No? Different layers will be seen in different areas of the abdominal cavity. Okay, so going back to the skin, as I mentioned earlier, the skin covering the abdominal wall is elastic. And this is the evidence of this. No? Uh, if you gain weight and then lose weight, or if you get pregnant and then go back to your pre-pregnant state, you will have these marks. So these are stretch marks, evidences of how elastic the skin will be. And usually these are seen as vertical stretch marks. They are perpendicular to your Langer's lines. Okay? So after the skin, the next layer that you will see would be your superficial fascia. So this is the supporting tissue immediately below the skin, and this is a layer of fatty connective tissue. It is a single layer and continuous with the superficial fascia throughout the regions of the body. So what do I mean by this? This is continuous also with the superficial fascia that you see in the chest, in the thorax, and likewise in the lower extremity as you go down. So remember, some structures of the anterior abdominal wall will be continuous as you go down the pelvis and even into the lower extremities. And this is one of them, your superficial fascia, because it is continuous until you go down the lower extremity. As you reach the point of the umbilical area, the umbilicus, it splits into two. You have a superficial fatty layer and a deep membranous layer. Okay, so here, so you see here the skin is removed already, and this is what you see, your superficial fascia. And as you reach the umbilical area, it splits into two. You have your campus fascia, which is purely a fatty layer, tissue, and this becomes continuous as you go down the pelvic area, and it crosses your inguinal ligament, goes down towards the thigh and the perineal area. In men, your compressed fascia will continue going to the area of the penis and the scrotum. And this will form part of the covering uh, that contains your dartos muscle. In women, this will also be continuous and this will form part of the fat pads in the labia majora. Okay? So what about the other layer? So the other layer is your deep layer or your scarpus fascia. If you're going to compare it with the Camper's fascia, your scarpus is more membranous with little or no fat. And the scarpus is a stronger layer compared to your Camper's fascia. Actually, this is the layer that we use to close or to approximate the abdominal wall, no, part of the abdominal wall. It continues below the inguinal ligament and fuses with the deep fascia of the thigh. So if you can recall your fascia lata, so it fuses with your tensor fascia lata, and it is firmly attached to the linea alba and the symphysis pubis. So doing a midline incision, you will cut through your scarpus fascia. And as it goes towards the perineal area, this becomes your superficial perineal fascia or your Colles fascia. Now the thing here is when you go into the inguinal region, what makes this area very difficult is that you have the same structures, but it changes its name at different levels or layers. So that makes the inguinal region very difficult, especially during surgery, because you're dealing with the same structure that changes its name depending upon the layer that you are in. Okay? So the next layer would be your abdominal muscles. So they are grouped into two major groups, the lateral group of muscles and the vertical or the anterior group of muscles. So the lateral group is made up of your external oblique, internal oblique, and your transversus abdominis. As I mentioned, uh, as it goes more anterior, the muscle is replaced by your aponeurosis as it continues towards the midline. Whereas your two vertical group of muscles will be enclosed by your uh, rectus sheath, which is the covering of your vertical muscles, and this is made up of your rectus abdominis and your pyramidalis muscle. So if you're going to dissect the abdominal cavity, removing the superficial fascia and exposing the muscles, this is what you're going to see. On the left side, okay, on the left side, you see here external oblique, here, on the internal oblique, immediately below the external oblique, and your transversus abdominis muscle. By orientation, your external oblique fibers are obliquely oriented and they are pointing downwards. That's the case here. Okay, so this is the midline. You see here your linea semilunaris. Your internal oblique fibers are obliquely pointed upwards, whereas your transversus abdominis will be oriented horizontal. The fibers are seen horizontal. So with regards to your external oblique, this is the most superficial. This forms part of the inguinal ligament. So here is your inguinal ligament. Okay? Inguinal ligament. Now, as it extends beyond the inguinal ligament, you will see an extension of your external oblique muscle. And this is your lacunar ligament or your Gimbernauts ligament. Now, the fibers of your external oblique along your pectineal line will form part of what we call your Cooper's ligament. So you get the idea what I am talking about earlier. So the same structure, according to the level in the pelvis or in the perineum that you see, structure changes its name, no? Becomes different, but actually it's one and the same. No? So external oblique crossing the inguinal ligament becomes part of the inguinal ligament. As it goes beyond the inguinal ligament along the medial end, it becomes your Lacunar's ligament or your Gimbernauts ligament. Along the pelvic brim, the pectineal line, it becomes your Cooper's ligament. Your internal oblique is smaller and thinner than your external oblique. And as I've said, the direction of fibers would be obliquely pointing upwards, superomedial direction. The last one would be your transversus abdominis. It blends with the linea alba as it goes towards the middle. And this is closely associated with all the other aponeurosis. So the next layer is that of your transversalis fascia. Here, the transversalis fascia. So note here that you have your rectus muscle here. This is your posterior rectus sheath covering the rectus abdominis muscle. And then, of course, in the front, you have your anterior rectus sheath. So this is how we dissect the layers, no? Layers and layers of abdomen, especially if you would like to repair something. So this is the dissection that we do whenever we repair for a hernia, an incisional hernia in the abdomen. Okay. So your vertical group of muscles, your rectus abdominis, and your pyramidalis muscle. So 80% of the population will have this. As I've said, uh, about 20 or even to about 40% of individuals will not have the pyramidalis muscle, but this will not affect the functions of the abdominal wall muscles. So in summary, let me direct your attention here in the table in your textbook showing you uh, the important points insofar as the anterior abdominal wall muscles are concerned. Okay, so they will differ only as to its origin and insertion, but by action, as I've mentioned, they are accessory respiratory muscles. Okay, so they aid in respiration, help your diaphragm in the process of respiration. Nerve innervation, pretty much the same. So usually they are innervated by your lower six thoracic nerves and in part by your iliohypogastric and your ilioinguinal nerve. Okay. The general makeup of your rectus sheath is somewhat unique. Remember, I mentioned the arcuate line earlier as a point wherein you have a transition between the covering of the rectus sheath. So your arcuate line is a point midway between the umbilicus and the symphysis pubis. So in this area, uh, the covering changes. So initially, your rectus sheath encloses the upper three-fourths of the rectus abdominis and covers the anterior one-fourth of the lower segment. So as it goes down, the lower one-fourth will become directly in contact with your transversalis fascia. So here, in your first illustration is the typical course of your coverings. So you have here the anterior rectus sheath, the posterior rectus sheath crossing the midline, your transversalis fascia. But here, B, so this is at the area of your arcuate line. Note that your anterior rectus sheath is here. The posterior end of your rectus abdominis muscle is exposed. No covering because your posterior rectus sheath becomes fused together and goes in front. Now the covering of your posterior, your the posterior portion of your rectus abdominis muscle would be your transversalis fascia. Okay. Contents. So what do you see within the rectus sheath? Well, apart from, of course, the rectus abdominis muscle, there are other structures that are seen confined in the rectus sheath. You have your pyramidalis muscle, if it's present, the superior and inferior epigastric artery and vein, which is sandwiched together between the rectus sheath and your rectus abdominis muscle, your lower five intercostal nerves from P7 to 11, and your subcostal nerve, your T12, will be seen here. That's why clinically there's one condition that is very important. We call this rectus sheath hematoma. A rectus sheath hematoma is uh, the pooling of blood in between the rectus sheath within the rectus abdominis muscle. And this happens either by number one, sustaining a trauma or blow in the abdominal wall, thereby producing bleeding. And usually the source of bleeding would be your epigastric vessels, your epigastric artery and vein. Number two, uh, if you are on the lean side, you're thin, and you don't have much supporting tissue protecting these structures, that can cause bleeding, especially if you have persistent coughing. If you have a COPD, which you expect that you will have persistent coughing, or even problems in the prostate, benign prostatic hypertrophy. So what's the connection with this one? These conditions increase intra-abdominal pressure, and the more intra-abdominal pressure that you have, uncontrollable, the higher the chances that you can have a rectus sheath hematoma. Those who are exercising in the gym, so lifting weights, um, more weights that the body will not be able to handle, the crunching exercises. So all of these are contributory factor for the formation of rectus sheath hematoma. So what's difficult here is the identification and diagnosis of rectus sheath hematoma because this presents as a surgical abdomen. So this simulates a condition wherein you need to immediately operate on a patient. But in essence, uh, if you properly diagnose rectus sheath hematoma, uh, there is no need for operation. There's no need for operation. On the contrary, what you need to do is just drain the hematoma, put pressure on it, and observe. Okay, so there's no need to open up the abdominal cavity for this one, as long as you'll be able to properly diagnose the presence of your rectus sheath hematoma. So the next layer would be your extraperitoneal fascia. This is deep to your transversalis fascia, and that separates your transversalis fascia to the peritoneum. In this layer, you have the majority of the blood supply seen. So the vasculature is located in this layer. And for us, we often call this as your preperitoneal area or your properitoneal area, the layer immediately before the peritoneum. So this one is the last layer. Okay? The last layer is your peritoneum. And the peritoneum is split into two. No? The outermost layer is your parietal peritoneum. And the parietal peritoneum hugs the abdominal wall. No? So remember, in the thoracic cavity, you have your parietal pleura and your visceral pleura as the lining of the thorax. Your parietal pleura is the infolding that follows the shape of the uh, thoracic wall, whereas your visceral pleura is that infolding which is closely adherent to the lung. So here in the abdominal cavity, the orientation is the same. Your parietal peritoneum is that infolding of the peritoneum that closely follows the abdominal wall. Okay? So that this is the last layer, as you can see here. When you make an incision here, you already gain access to the abdominal cavity. So blood supply. Well, since this is a big area, you have a rich supply of blood in the area. If you are looking at the midline portion of the abdominal cavity, this is supplied by your superior and inferior epigastric arteries. And now as you go more lateral, as you go to the flank area, uh, you have several arteries that will be supplying blood. Likewise, you have your intercostal arteries, your deep circumflex artery, your posterior intercostal arteries, and your lumbar arteries. So it goes around from the midline going towards the lateral portion of the abdominal wall. As you go towards the inguinal region, you also have several arteries supplying the area. You have your superficial epigastric artery, your superficial circumflex iliac, your superficial external pudendal, and your femoral artery branches. So a lot of blood supply, right? So that's what you have to be careful in making your incisions or dissections in the area. Otherwise, uh, that can cause bleeding in the area. Venous drainage. Okay. So we follow the same rule. For every artery, there would be a concomitant vein that will drain the area. Now, the unique part here is that if you are draining the upper abdominal wall, venous drainage will go through the axillary vein. And this is via your lateral thoracic vein. So the drainage will be going up, going up. If you are dealing with the lower abdominal wall, drainage will be via the femoral vein, through your superficial epigastric and your great saphenous veins. So two-way, no? Upper abdominal wall, lower abdominal wall. Upper going into your axillary vein, lower into your femoral vein. The lymphatic drainage will also follow the same line as your venous drainage, so that any disease or abnormality above the umbilicus, drainage will be going to your axillary nodes. Below the umbilicus, it goes now to your inguinal region, your inguinal lymph nodes. The rest, this can drain at the central area via your parasternal nodes, your lumbar nodes, and your external iliac nodes. Okay, nerve supply. No? So I mentioned that the nerve supply comes from the lower six thoracic and first lumbar nerves. And this is the distribution of your nerves. Now, point to remember here is at the level of your xiphoid, the innervation is your T7. At the level of your umbilicus, that's T10. And inguinal ligament L1 here. Okay? So, what is the importance of this one? Uh, I asked earlier about acute appendicitis, right? And Dr. Magalong mentioned that he experienced first periumbilical pain before gradually uh, going into the right lower quadrant. So typically, since the nerve innervation here would be pretty much the same as all the areas of the anterior abdominal wall, what happens here is the initial pain perception would be non-specific, non-specific in general. So, like this one, there is an evolving acute appendicitis, but the initial pain came from the periumbilical area, not the level of your T10. Why T10? Because as you can see here, T10, T11, and T12, your appendix will also be at this level. So that it starts off here at the level of your T10, and then after several hours, when the body uh, realizes that the ongoing change or abnormalities in the appendix, then that's the time that the pain will settle down in the right lower quadrant. Or for acute cholecystitis, it's the same. Also, it starts off in the epigastric area and then gradually go into the right upper quadrant area. So it initially starts off as non-specific and then later on localizing to the specific area of concern. Okay. So there's an area in the anterior abdominal wall which is a potential area for uh, bulging, no? Or masses protruding in the abdominal wall. And this is what we call your Hasselbalch's triangle. No? So why a potential space? Because normally one of the changes that occur would be as you age, the the structures become thinner because of the constant wear and tear. So because of age. And at this point, this is the most common area wherein you have bulging or formation of hernias, specifically that of your direct hernia. Okay? So this is bounded by medially by the lateral border of your rectus abdominis muscle, by your inferior epigastric vessels, and your inguinal ligament. So this area is what we call your Hasselbalch's triangle or the medial inguinal fossa, which is a potential space for direct hernia, especially in the elderly. So any condition that I mentioned earlier that increases intra-abdominal pressure can aggravate the formation of hernia. And one of the most common locations will be here. in the area of your Hasselbalch triangle. Okay, so I think we stop here for a while. It's 9 o'clock. Any questions? Questions?
Wala po, Dok.
Okay. So you're already saturated after 1 hour. Huh? So you're beginning to show signs of intellectual diarrhea. Huh? Intellectual diarrhea as defined as absorbing information coming in from